Okay, now it's getting ready.
Yeah. I have a question, please. We have in the module 1 some text related to biostatistics.
Yeah,
So
exactly.
do we need to read it? I think maybe it's going to be helpful for the module 2.
I have to just see why I have two recordings now, but it's recorded live. Okay. Yes, I mean, I wanted to say that during the presentation, I'm going to do that. Yes, indeed, you have an introduction to statistics, and it was designed, I mean, in a way that you have the minimum kind of information that you need. Confidence interval, I mean, distributions, I mean, all these kind of things that I personally think you have to know. Okay, because it's going to be very difficult to now I'm back to that, and I will again okay. So I will provide you with the link, but I'm certainly encourage you to go. And if you have questions, what I'm going to do is that I'm going to pool the questions, and then I will ask Pascal Anderle, who is really the one that was giving the statistical course, to join for a special meeting on statistics. In addition, I will also provide you with a link to workshops that we had done with HVTN, the HIV Vaccine Trial Network, and NIH, okay, in which we had 3 meetings on statistics analysis of HIV trials. And it turns out that 2 of the speakers are in fact part of our academia, HZ academia, and the 2 of them would also be ready to answer questions that you have, okay? And if you would like to have, I mean, a special lecture, I could also organize that for you, okay?
Yeah.
So
will it be like statistics 101 sort of introduction lecture, or will it be questions that?
I mean, it depends, you know, I mean, depending what you want to do with in the analysis of the trials, you have some Bayesian statistics, which are pretty elaborate, okay? But for the time being, try to read what is in the basics of statistics that is in module 1.
Yeah,
and okay. If you want to know more, okay? So, Amy, I'm going to answer your questions, and I'm also asking you a list of questions. What are the characteristics of the vaccine that are needed to meet the medical market? How important are the context and the constraints for a COVID-19 vaccine? In which population is there a medical need, and so on? I will actually go through these various questions, which probably you have been able to see, and then you tell me what your answers are for these questions, and I will then provide you with what I think the answer should be. Okay, so the next meeting exceptionally will be next week, June 23. And the reason is that Ivana Knežević is not available on the days like today. I mean, so so if we start 23 of June, and every other week, every other 2 weeks, you will be able to participate, which I think is absolutely crucial for this module. So to your question, okay, Amy, what is an adaptive trial? An adaptive trial is defined, I mean, you have 2 definitions. One is by the FDA and one is by the European Medical Agency. An adaptive design is defined as a clinical trial design that allows for prospectively planned modification. And prospectively is very important because this has to be present in your TPP, and it has to be present, I mean, in your description. You cannot add it just like that, okay? It has to be planned. So this is a modification to one or more aspects of the design, and it is based on accumulating data. So as the trial goes, I can show you this here. I have this, can you see it?
Yeah.
Okay, so you can see here that it's a no-go. This is a no-go also. And then suddenly here, it's a go, okay? Because there were no report of adverse events. And so you have go, no go, and so on. So the trial keeps going, and you are going to look whether it's immunogenic or not. You can see here that it's outside the confidence intervals. So this one can go, but this one cannot go, okay? So then you continue with those ones that pass this test, and then you can see that here you have a positive signal and consequently can go. And that's very different from a traditional system where you have to finish the phase 1 and then you start a phase 2, and that can really be quite annoying, okay? So here it's a way to actually save time. And when you think about COVID has even gone one step further, because in COVID, you did almost simultaneously a phase 1, a phase 2, and a phase 3, okay? So that's the way that they were able to accelerate the development of the vaccine. And the definition of the EMA is not very different. It says that if it's adaptive, if the statistical methodology allows the modification of a design element, and I showed you how the statistics enter with the confidence interval, okay? So you can change a couple of things during the assay, which will save time. Here is the link that you can go and see again on the adaptive trial design, which is on the website, okay? So you are welcome to go back and see that and read that, and that's where you have, I mean, the animation I just showed to you, okay? And that was actually present in the HIV trial, the adaptive trial designs for HIV vaccines, okay?
Yeah, no, that was very clear. And I actually did a search within the course and found the animation. It was the alpha spending, like I said, that I didn't really understand because I couldn't find it anywhere else to but what you provided was sufficient.
Okay, great. So I come back to this, okay. Here is the introduction to statistics. Okay, you can see that you have really the main topics, and this is in module 1 under, I think if I'm correct, let me just show you that where it is so you will find it easily. It's here, it is under the 1, and here under on vaccines. To know more, that's where you have the statistics, okay? And then you can, I mean, review this. Okay? Clear?
Yes.
Good. So I'm back here, and you ask, so I'm not sure whether we understood really the adaptive trial. It's really a way to actually gain time, okay? Where you analyze, you don't go to the end of a phase. In interim analysis, you will see whether you have already some information that allows you to stop or to go. Okay, it's a no-go decision that has to be taken. And the go, no-go decisions are very, very important in the trials that you do in vaccines, okay? It will save money and it will save time. So here is the alpha spending function, and I provide you with a paper. I think it should open it, yes. Here it is, an interim analysis, the alpha spending function approach, okay? So if you're interested, you will be able to read that. And basically what that does, it allows flexibility in the number of interim analyses to be conducted and at different times, okay? Here you have actually the way that this is calculated, but I mean, really what this does is that it provides you with information to quantify your budget to spend, okay? So if you're interested, read it. And if you have very specific questions about, I mean, this alpha spending function, which I didn't know where you find it. I mean, Amy.
It was in there was a mention of it in the first section of vaccine development when it was talking about adapted trials, and it talked about, it was just a small line about alpha spending, which again, I couldn't find anything else.
No, but it's very good, I mean, to ask this question, okay? And of course, I mean, these analyses are based on the type 1 and type 2 errors, which is also based on null hypothesis. So I really would encourage you to go there. And if you have questions, I will then gather all these questions that you have, and we will organize a meeting with Pascal Anderle. Okay, so next is what are the typical attributes of a TPP? So the target product profile, which is abbreviated TPP, is a specification document summarizing the expected characteristic and performance of a vaccine that you want to develop. And what should a TPP contain? It should contain the indications, target population, safety and reactogenicity, contraindications, dosage and schedule, interference or co-administration with other vaccines, the route of administration, product presentation, the product formulation, the storage and cold chain requirement, the packaging and labeling, and finally, the product registration and pre-qualification. So we will go through these different aspects. So how important are the context and the constraint for a COVID-19 vaccine? Listen to you. Have any idea? Do you understand the question? Here I provide some help, okay? Okay. How important are the context and the constraint? Okay, it's, as you know, for COVID-19, there was a sense of urgency. And the other thing is that the feasibility of a quick scale up of supply is absolutely crucial. As you know, I mean, this vaccine is produced to actually be administered not to a few 100,000 people, but to, I mean, billion people in the world. So this is a real problem. And I think that most of the companies do not have the capacity to do that. That's why there was an offer, for instance, from GSK and from Sanofi Pasteur, actually to make available the plants that they have to produce the vaccine. The manufacturing cost should decrease sharply with increased scale. So the more you produce, the more the cost of the vaccine and the manufacturing should be important. And the technologies should already be used in licensed products, okay? So if you can use a process that has already been used, that will also gain a lot of time. And finally, the raw material that is necessary for the production of the vaccine should not be limited. So that constraints that you have with the vaccine, and especially with the COVID-19 vaccine. Do you have a question?
Yeah? The feasibility of quick scale up of supply, is that how the availability of it? I'm not sure what that it means exactly.
What
the feasibility of quick scale up?
I mean, the feasibility, okay. Do you have, I mean, the resources and the equipment and everything so that you can rapidly scale up the supply? I mean, if you have to deliver, you know, when you do a classical trial in a phase 1, you are going to have probably 100 to 1,000 volunteers. If you go to a phase 2, you will have probably something like 2,000. If you go in a phase 4, you have 40 to 50,000 people. But if you do now what has been done for COVID, okay, with the accelerated process that the FDA and the EMA have accepted, you have to provide the vaccines to billions of people, okay? And is that feasible? Okay, so that is something that you should know ahead, okay? Because if there are problems, I mean, in the design and in the production of a vaccine, you will not be able to meet the need. Okay, that's what it means, the feasibility of quick scale up of supply. So you should know if you have, let's say, a vector-based vaccine, okay, a virally vector-based vaccine, how many units can you produce in per cells and then in a bioreactor? Okay, that is probably known for many of the approaches. Okay, and that's what you need to know in your, and you have to put that in your TPP. Clear?
Yes.
Okay. So you can see, for instance, ranking the 4 vaccine platform according to criteria for harmonized target product profile, safety and reactogenicity. Okay, for the RNA vaccines, you have a score of 24 out of 30. For the viral vectors, it's 21. For protein, it's 24. And for inactivated viruses, it's 30. So you do that for the safety and reactogenicity, you do that for the efficacy, you do that for the logistics, that's the feasibility of the quick scale up and supply. You do that for the cost of goods, goods sold, okay, the COGS, and you have a total score. So you can see that the messenger RNA score 82, the viral vector 72, the protein-based AD and the inactivated virus 71. So this gives you an idea of what is going to be the criteria that you have to meet in your target product profile in order to be able to actually, because this document is going to... Yeah? Sorry, I didn't understand. Did you have a question? No? I thought that there was a question. Okay, so that's what I wanted to let you know. And I think if you have time, it's maybe interesting to read this paper, because in fact, there are very few papers that have actually looked at that. But here, this paper from Funk et al., which I have just indicated here, might allow you to better understand what it is. If you cannot find it, I will send it to you. Okay? So what are the indications? What should the vaccine do? So can you tell me, what would be the indication for COVID? Could be different for other diseases, but for COVID, for SARS-2. What should the vaccine do?
It should provide protection.
That's correct. It should
Reduce
protect.
the death and the severe disease.
It should protect against severe disease. Yes.
And
Something.
also reduce the number of hospitalizations because the cost is really high.
That's exactly right. Okay, so it should prevent the COVID-19 infection. So that's this here. It should prevent SARS-CoV-2 shedding, which is going this way. If you shed the virus, okay, you can infect other people, okay? And this is not easy to determine whether actually transmission is prevented by your vaccine. And usually you need to do that in a large phase 3 and eventually in the post-marketing phase, because what you have to do is to show in a large group, okay, which are the vaccinated person that still get infected, okay? From that, you can see whether the transmission has been effectively blocked or not. So this is an important parameter to determine. And the reduction of the severity of the disease, for instance, can it prevent the pneumonia that you find it, okay, in the disease. So infection, transmission, and the disease. These are the indication of your vaccine. Ideally, what would you like to have, I mean, by your vaccine?
Immunity.
Yeah, but I mean, ideally, of these three information I just put here, what would you like to do? Only one, or ideally?
All.
Oh, yeah, I was going to say all.
Yes, you would get them all if possible. But if you would, I mean, if you have a vaccine that already reduced the severity of disease, and your vaccine is not able, for instance, to prevent transmission, there might still be interesting to have this vaccine going into people, okay? Because then you will decrease the number of deaths, okay? So, and of course, I mean, you have the individual benefit, but you have also the public health perspective. And for instance, if you can prevent the transmission, prevent the disease and the SARS-CoV shedding, even without symptoms, you are in a much better position. I think we've discussed that already when we were in module 1, okay? What do you think is required for the virus actually to prevent shedding? Do you remember? Which arm of the antibody which arm of the immune response do you think would be the most efficient to actually prevent transmission?
The antibody response, humoral response.
Do you think it's the humoral? But I mean, if you think about Mariam, the virus infects the respiratory tract, okay, and this is shedded again out. Okay, where are the antibodies that would prevent?
Yeah, it's the it's the cellular immunity.
Yes, it's the cellular. If you have a good CD8 response, a very good CD8 response, it will actually kill the infected cells, and this will be. And I told you, I mean, I gave you a reference from a group in, I think, in Harvard, where they looked at what kind of response you are going to stimulate, both by the natural infection, but also by the vaccine. And CD8 is actually usually quite well induced. So that might be the mechanism. But it's not, there are not enough data actually to really tell you exactly whether the transmission is for sure prevented. Okay? Now, what is the case definition for coronavirus disease 219 as of December? Have you seen this question, and do you have an answer to that or not?
I don't remember seeing it.
Okay. So there are a number of criteria that allows you to define the case for coronavirus disease. You have clinical criteria. For instance, any person with at least one of the following symptoms, cough, fever, shortness of breath, sudden onset of anosmia, okay, the smelling is perturbed, or ageusia or dysgeusia, which is the taste, okay, is perturbed. You should take that very seriously as a sign for a COVID infection. But it's maybe not enough. So we'll need diagnostic imaging criteria, for instance, radiologic evidence showing lesions compatible with COVID-19. What would be the lesions? Where would you look for the diagnostic imaging criteria?
The respiratory tract?
Yes, you would do X-rays of the lung or a CAT scan or something like that, okay? There are laboratory criteria, the detection of the SARS-CoV-2 nucleic acid in a clinical specimen. Usually you take a swab of in the nose and then determine whether you can find actually the nucleic acid for SARS-CoV-2. I have my cat that is annoying me, okay.
She wants to learn.
No, because yes, he's eager to know, and he likes to play on my computer. Stop it. Okay, so then you have epidemiologic criteria. The contact with a confirmed COVID-19 case in the 14 days prior the onset of the symptom. That's going to be very important. You have to trace, okay, all the people that have been in close contact with an infected person, okay, so that you can actually put them in quarantine. At least one of the following two epidemiological links: the close contact with a confirmed COVID-19 case in the 14 days, as I said, and having been a resident or a staff member in the 40 days prior to the onset of symptoms in a residential institution. So these are very important criteria, in fact, to be able to notify where are where are the infection taking place. And then you have case classification. The possible case is any person which meets the clinical criteria. The probable case is any person meeting the clinical criteria, but with an epidemiological link, or any person meeting the diagnostic criteria, okay? Then you have the confirmed case, that all the person that actually, all the person which have a laboratory criteria. So this is something that you also have to put in your TPP so that you know how you are going actually to follow the infection and of course the effect of the vaccine on the infection. Correct? Clear? Is that clear?
So, but when you're putting this in your TPP,
yes,
are you hypothesizing the case classification at that time? You're thinking of the possible, probable, and confirmed, you know?
You are right, but I mean, you know already, it's usually when you start a vaccine development, you know already that you have tools actually to detect the disease. You already have epidemiological studies. That's why when you will do the design of a vaccine yourself, a new vaccine, you will need the epidemiologic data, you will need the diagnostic data. These things usually are already available, okay? They are maybe not perfect, but they are available. So you have to put that in the TPP, all right? And sometimes you have to say, okay, as things go, we will use, tools that are better adapted to follow. You see, the TPP is something that gives you exactly the way that you want to organize all your different steps in the vaccine development process.
Okay.
Yeah.
Yes. Yes. So
okay.
you're using the epidemiological criteria and from things that have done in the past. Therefore, you're making that that case classification based on the information that you have. Is that correct?
That's correct. Yeah.
Okay. Perfect.
Okay. So come back. I said that here you have a link which gives you, I mean, what I just described, okay, these different criteria and the case definition for coronavirus. I always like to provide you with links. That doesn't mean that you have to go necessarily to actually read this material, because I already picked out some what is essential here. But I mean, you know that it exists and it's not the fantasy of your tutor. Okay, target population. Okay, in which population is there a medical need?
The vulnerable population, usually the elderly.
In this case, it's the elderly. Is it always the elderly?
No, it's
No.
a pregnant woman, the immunodepressed people.
Mm-hmm.
I mean,
And it could be children as well, depending on
okay. But I mean, normally what you are going to do is that you define an adult population, okay, or a children population, okay, and you aim, as we said, to prevent the disease. The efficacy should not decrease with age, ideally. Mm-hmm. So that means that in your TPP, you will have to actually characterize the population. And for instance, one of the problems that we had with COVID is that the AstraZeneca, they didn't have enough elderly people, okay? So they had then to go back and look at elderly people, okay? So you have really to think about what is your target population. And now you have questions also. You've mentioned pregnant women and immunocompromised people. We will come back to that. Can you actually include them, or do you have to exclude them in your study?
No, exclude them.
Are you sure that you have to do it? Okay, you are right. Okay, usually, and for most developing vaccines, that's an exclusion criteria. You're right. Okay, we'll come back to that. Now, comorbidity, increasing the risk of fatal COVID-19. Okay, if you have diabetes, you have hypertension, all that, okay? Would that prevent you from vaccinating people? That's the question, okay? Mm. And then you have the pediatric population. Why would you immunize with COVID-19 the children? Because they are really sick, okay?
But they could be spreaders.
Yeah.
They could be.
They could be spreading the disease.
Exactly.
Even if they're not sick.
It is to prevent the virus shedding, okay? And that's why. But you see now, when you look at COVID-19, okay, they did the study for adults and elderlies, okay, especially for Moderna and Pfizer's. They included that. But now they have to go back to the children, the adolescent and the children, because they were not included. So you cannot go right away, I mean, with your vaccine. So you need to do a safety in these populations. But again, what I find very interesting in the case of COVID-19 is all these things go almost simultaneously. I'm so impressed of the amount of work that has been done in the last 1 year and a half. It's amazing. The definition of age, okay, this is a definition I gave you, which I think comes from this paper, okay, this document. One defines the preterm newborn infants, the term newborn infants that are 0 to, I mean, the preterm, these are the fetuses, okay, and okay. The term newborn infants are from 0 to 27 days. The infants and the toddlers are between 28 and 23 months, 28 days and 23 months. The children from 2 to 11 years, and the adolescent from 12 to 16 and 18. So as you can see, I mean, maybe you knew that, but it's not so obvious how you classify, I mean, the pediatric population. And that again is an information that is important to know when you write your TPP, to know exactly which group you want to actually target. What is acceptable in terms of safety and reactogenicity? That's my question.
So the vaccine is not inducing severe side effects.
That's correct. You don't want to have a severe adverse events. Okay, but in terms of reactogenicity, have you seen a little bit what are the main complaints of the people that get vaccinated? What is it?
They have soreness at injection site. Some could have malaise, headaches, low-grade fever.
Vomiting.
Is that acceptable?
Yes.
Yes,
it is. So you have a grading. I mean, I didn't put that in, but I think it will be someone in module 2. You have a grading of reactogenicity and safety. I mean, adverse event. Okay, and it's going from 1 to 5. Okay, 5 being death. Okay, so 1 is usually accepted. So you also have to actually prepare, I mean, in your TPP, what you are going to do in case you have a very severe adverse event. What are you going to do? This has to be written, okay, that you are going to stop the trial, and you have to know how one stops a trial. Okay, you see?
So then, is there a classification in terms of what constitutes? Well, okay, obviously a severe event is death, right?
Yes, it is classified. Yeah. Clearly, it is.
Yeah.
And here I show you what has been done with people that have COVID and people that did not have COVID in response to a vaccination. So you can see that here you have any of the side effect, okay, and can see that it's really not going above this is minimal severe. It remains in an acceptable form, okay? And then you can go and see for instance, flu-like illness. You can go for triggering. You can go for anaphylaxis. Do you consider that serious or not, anaphylaxis?
Yes.
Yes, severe.
Yes, it is serious. So you can see that, I mean, the number of cases of anaphylaxis is really, is not detected. But this is why do you think it's not detected here in this study? Any idea?
Maybe because it didn't happen.
No, because
yeah, go ahead, Mariam.
People who are having allergia or are not having the vaccine, are not getting the vaccine.
The problem is that how many people do you have in the study? And if you have a frequency of an incidence of, let's say, a serious anaphylactic shock, which is 1 in 100,000, you will not pick it up in your study. You see? Yeah. So that's why this kind of what is accepted in terms of safety and reactogenicity will not be only collected during phase 1, 2, and 3, but it will certainly be collected during phase 4. That's exactly what happens with COVID-19. You have this thrombocytopenia and thrombosis, okay, that have been reported, which are very severe problems. I mean, with the death due to thrombosis in the brain, okay, and the anaphylactic shock also are things that have appeared. Now the problem is that anaphylactic shock, you can treat it with a thrombosis in the brain. It's much more difficult to treat. Okay, so these are very important things that you have to have in mind. You have to kind of I mean, predict what could be the reactogenicity and some severe effect based on the experience with other vaccines and so on, okay? But sometimes you cannot predict everything, okay?
Jean-Pierre, when you said oh, sorry, never mind. I read it wrong.
No, it's easy to assess reactogenicity.
Yes, it's easy to assess. Yeah, I had read it incorrectly, so no, that's fine.
Any risk of disease enhancements? What do you know about disease enhancement? You probably remember we have seen that with dengue.
Yeah, it's the ADE, the antibody dependent.
Yes, exactly. So it depends. For instance, for dengue, it was very clear. You have four serotypes. You have neutralizing antibodies against this serotype. And it was clearly shown that none of the vaccine, whether the Japanese or the Sanofi Pasteur vaccine, was actually able to generate an equal amount of neutralizing antibody. So you might have, for a serotype, a given serotype, a very weak response. And when you are exposed again to this serotype, the antibodies that you have will actually not neutralize because they're not enough. So they will bind the virus, and through the FC receptors on cells that can take up the virus, it will then help to proliferate, I mean, to produce more virus that will infect more and consequently give a severe disease. So this is something that you have to think about. And you also, for instance, for the coronavirus, you will have to go and look whether the infection with the SARS-1 that took place in Hong Kong generated this kind of thing, okay, this kind of problem. That's the one you have to do. The other thing that you have also to look at is the cytokine profile, because it is known that if you have a Th2 response that is taking over the Th1, then you might have problems, okay? So you do have to take this also into consideration. And some of the safety issues, as I just said, will only be seen once you have a large number of volunteers which have been immunized and a significant number that have been naturally challenged. So that cannot be quick, okay? That cannot be, you have to mention that in your TPP that you are going to look at that, but you will have to look at in a phase 4. So you have to, again, plan that and say the way that you are going to look for these different aspects. Clear? Mm-hmm. Is there contraindication for the COVID vaccine? Who should not be vaccinated?
Compromised people, pregnant women.
Yes, you said it. Okay, there are no contraindication for comorbidity because it's no increased severity of COVID-19 has been linked to the vaccination of people that have hypertension, diabetes, asthma, permanently liver, or autoimmune diseases. So you have to realize that COVID can actually be more severe in these comorbidities, but the vaccine is not accelerating this kind of problems. Okay. Now, immunodeficiencies for live vaccines. None of the presently available COVID-19 vaccine can cause the disease, okay? No of the vaccine caused the disease. Therefore, the safety profile is the same for immunocompromised and normal individuals. You understand that?
Yeah.
I have a question, sir.
Yes, go ahead.
How about people who diagnosed positive with COVID-19? Were they being immunized immediately, or they have to wait for a period of time?
I think you're right. That's a good question. I think one waits a little bit. Okay, usually the time now it depends. Okay, some people think one should wait for at least 2-3 months, and others provided other numbers. But indeed, you're right. If you had COVID, you should wait. First of all, when you have COVID, you do elicit an immune response to COVID. So the best thing is to select a time when you will boost the immune response with your vaccine. But I don't think that personally, if you vaccinate someone that had COVID immediately, that you are going to put this person at risk. But I think the advice is that you have to wait. Okay, is that answering your question, Diamond?
Yes, you have answered it.
Great. Yes.
I have another question.
Yes.
Current India, they are not vaccinating pregnant women.
Yes.
But some literature has been showing that COVID-19 vaccine, there is a possibility of it being passing through placenta and prevent the baby. I don't know the current schedule. What are they recommending for pregnant women? Because some countries.
I come to pregnancy. Okay, as for all vaccines, in the pregnancy, you usually do not vaccinate pregnant women. But in this case, all the currently authorized COVID-19 vaccine can be administered to pregnant and lactating women according to the CDC. Okay. So in this case, and this answers your questions, because if you immunize a pregnant women, the pregnant women will accumulate first the antibodies where you have two ways, I mean, that you can transfer passive immunity to
the placenta?
Through the placenta, which then go, I mean, in the placenta, there is a very efficient transport of IgG mediated by FC receptors, neonatal FC receptors, so that it goes in the blood of the newborn. And after birth, it is mediated by milk, and there it's the secretory IgA that are doing the job. So now the question is that if you vaccinate the mothers with an injected vaccine, I'm not sure that you are going to generate a flock of secretory. Okay?
I guess that would be another study, wouldn't it?
Yeah, right. Then there is another thing that you have to know, okay? And you should be aware of the risk of the venous thrombosis and thrombocytopenia. It's a rare event, okay? But I mean, in a pregnant woman, you have at least to tell them that that is a risk, okay? I personally would not recommend the Ad5-based vaccine. I mean, the AstraZeneca or the Johnson & Johnson to pregnant women, because there it has been linked to adeno-5, okay? So I would certainly not favor this type of vaccine. I would go for the messenger RNA vaccines.
Yeah. So for pregnant mRNA vaccines are more safe.
They are given now. They are given now to pregnant women.
Yeah. Okay.
Yeah. Here in Switzerland, we immunize, I mean, pregnant women with the RNA. I mean, only two vaccines have been actually accepted in Switzerland. It's the Pfizer and Moderna.
Mm-hmm.
Okay. Interference and co-administration with other vaccines. I have to say this is not required for the launch of your vaccine, okay? But in the future, for instance, for the COVID, co-administration with the flu vaccine should be not only possible, but should be desirable, okay? And I would like just to tell you, have you heard from the press that Novavax came out with a new vaccine, which is 90% efficacious? Mm-hmm. And you know what? Yeah, have you seen it? So what is very interesting is that Novavax, it's a subunit vaccine. It's a protein-based vaccine, which also is, in my opinion, very interesting because the cold chain is not as stringent than for the messenger RNA virus. You can store it at 2 to 8 degrees. And for the developing world, this is much easier. But what they did already Okay, they now are ready to register they registered their vaccine, but I mean, they are ready to go, but they have to find a partner to produce their vaccine because again, it's a small company, okay? They do not have the facilities to produce enough vaccines, but their phase 3 trial is impressive. I mean, it's really amazing that a protein-based vaccine actually generate a 90 to 96% efficacy. That's unbelievable, but I mean, it's true, okay? Now, what Novavax is doing, they are now registering a combination of flu and of COVID-19. So that will be also probably on the market. That's a very good idea. Are you tired? You know why I'm asking this question? Because I have already spent an hour. You're okay, good. I'm soon finished. Okay, dosage and schedule. What is ideal? In terms of the dosage?
One or 2 doses.
The minimum.
Depends to the vaccine.
Sorry, who is speaking?
Depends to the vaccine.
Ideally, do you want to give this schedule, I mean, once, twice, 3 times?
Once, ideally.
It depends to the vaccine.
Ideally, preferably 1 dose. Only one.
Yes, Johnson 1.
It's the
and
Johnson.
AstraZeneca 2 doses.
I think you
and Pfizer.
You are speaking, Adele. Okay, keep going. I didn't
2
know.
doses for AstraZeneca.
Yeah.
2 doses also for Pfizer and 2 doses for Moderna.
Yeah. I mean, for Moderna, I think the second dose is boosting the response. Okay. We have just a release from our regulatory agencies telling that the Moderna and Pfizer vaccines provide a 1 year protection. And initially they thought it was 6 months. So now they are at 1 year. Could be longer, okay? Because I mean, the reason why I say could be longer, because there has not been enough time to see whether, I mean, the response. But ideally it's 1 dose. What would be acceptable? A single dose for short-term protection, that's what you said. I mean, Adele, that's correct. A second dose for longer duration, but with a maximum of 1 month between the 2 shots. So that's acceptable. What is not acceptable is what?
Please, I have 1 question.
Yes.
Yes, about AstraZeneca.
Yeah.
The first time they said that it's 1 month and then 2 months, and now they said 3 months for the second doses.
Yes. So what do you think the problem is?
Because now people are a bit more confused.
Yeah, they are confused. But I mean, the problem is that why do you have a delay between the priming and then a boost?
For example, the second people who take the first dose, it was the second dose, it was after 1 month.
Yes, but why 1 month?
Yes, and now the WHO said that it's good to wait 2 months or 3 months before the second doses. Yes. And they said that the efficacy is high after 2 months than 1 month.
Right. What you have to think about is that, and this was discussed in module 1, okay? When you give a vaccine, you may have more than 1 injection to prime. That's no good, okay? That was the case, for instance, for the dengue vaccine, where they gave couple of injections to boost, I mean, sufficient, not the boost, but to have an induction of a primary response which was sufficient. The delay that you have between the first, I mean, the priming and the boost is due to the fact that there is a certain time that we know, the time for which you are going to induce memory cells, because the boost is going to stimulate memory cells, okay? So Adele, when WHO says that we can now go through 3 months, this is because the studies have been done, okay? And you realize that when you wait a bit longer, you also have a very good response. And why are you increasing the time? It was just because in some countries, they didn't have enough dose, okay? Doses to inject. So they decided to give them more generally to more people and then extend the period for before the second dose, because they didn't have enough for the second dose. That was the reason, okay?
Okay, I understand now.
So I think what is not acceptable is more than 2 shots, okay? I have to say that I just vaccinated myself against tetanus and diphtheria, because I realized that my last injection was 7 years ago, and this vaccine doesn't last more than 7 years. So I boosted myself. So that here doesn't mean that you cannot boost, okay? And in fact, it's already recommended for the messenger RNA vaccines that a boost should be given at least 1 year after the first dose, okay?
So would that also fall within the plan if you're thinking of
yes,
the booster? And so then that would be under the acceptable category?
Right. I mean, what you have to provide, I mean, from your animal experience is that you know already that the vaccine is immunogenic, and you already have an idea of the schedule, okay? So yes, in your TPP, you have to plan that, okay? And say, yes, we will do a single dose, but you can also say, yes, we do a single dose and we will measure the response, and we plan to have a second dose if the antibodies are not sufficient. You see, this is exactly the kind of planning that you do. You think about what could happen. It's the same that for an adaptive trial, okay, the trial is planned in advance, okay? You have to kind of say, okay, if I have that, I can do that, okay? And this has to be written.
Okay.
Okay, thank you.
Okay, and what is also very important is that if you have to have a dose of viruses, for instance, for live vaccine, which is so high in order to stimulate a response, that means that you will not be able to produce sufficient vaccine, okay? So that would also not be acceptable. Got it?
Yeah.
Okay. Route of administration for COVID, what do you think would be the ideal route?
Intramuscular.
Okay, other opinions?
I mean, yeah, I was gonna say nasal would be, you know, if that one was developed because it's respiratory, but.
I have to say that it's very interesting. I've been working a lot on nasal immunization in humans also, okay? And one of the problem is that with a messenger RNA virus will be very difficult to actually formulate your vaccine so that you can give it by the nasal route, okay? If you have a subunit vaccine, a protein-based, you have to make sure that the vaccine stands the pH in the stomach and the proteolytic enzymes in the gut, okay? But if you have inactivated live vaccines, for instance, an adeno or something like that, we have done studies for HIV. It's amazing, okay, because in women, we have done the study, you actually generate a much stronger vaginal response by nasal route, by intramuscular route, okay? Wow. So the problem is that the scientific community is not ready to accept a mucosal route. I can tell you, okay?
What?
They are not ready, because the problem is that if you have a viral vector, okay, or an antigenate virus, it's a genetically modified organism, okay? So you have to make sure that it's not going to be released in the environment, and then the environment, it's not at risk to put population, okay? To see, if you think about the oral vaccine for polio, okay, there were really serious problems, okay, because the virus, the vaccine actually was able to revert and cause poliomyelitis. Okay, so unfortunately, the community is not ready for really a vaccination but I think it's something that might come back in the future. Okay, so what would be the ideal route? Intranasal, yes, but we've discussed it. You were right, Amy, the intramuscular and subcutaneous route, and intramuscular is the preferred one, because you know exactly that what you inject is in the body and is not dispersed, okay? There is an interesting approach, which is the patch. For instance, if you think of measles, there has been an attempt to eradicate measles. But that means that if you have a vaccine that you inject, in certain remote places in Africa, there are absolutely no facilities to actually inject the vaccine, because not everyone can inject the vaccine. Mm-hmm. So one of the students of IMVACC, Nicolas Perrault, worked with WHO to develop a measles patch vaccine, which is currently tested. There are, consideration in terms of producing the vaccine. Okay, it's not obvious, but just to tell you, this is an approach that can be envisaged. What is possible on the short term? Of course, the IM subcutaneous route is the obvious short-term choice. And that's what I had to say for the route of administration. Though, again, Amy, these are things that you have to put in your TPP. The product formulation, okay, the question is, how are you going to formulate your vaccine? For instance, if you have a subunit vaccine, a protein, you will need probably an adjuvant. Are you going to have your vaccine in a liquid form? Are you going to have it in a freeze-dried form? Are you going to dry it on a patch that I just mentioned? So for the adjuvant, alum is actually the obvious choice right now, but there are more and more adjuvants. Think of GSK that has the azo and new, adjuvants that are very efficacious, and that have been accepted by the regulatory agencies. So you have to select and discuss what you are going to use in terms of an. If you have a liquid presentation ready to inject, the flu vaccine is a model where you have the syringe, the vaccine is in the syringe, and you just can inject right away. The freeze-dry, it's possible for live vaccines, okay, but it is costly because it needs costly equipment, and it needs 2 vials, one for the powder and one for the diluent, okay? So there are also difficulties, but it could be done. So that is aspects that you have to put and discuss in your TPP.
So wait, I'm sorry, can we go back again? When it said dried on a patch, wouldn't you need some sort of like absorbent gel to get into it's topical, right?
Usually, so, yes. But what you do usually, you freeze dry it, okay, and then you apply it on the patch.
Oh, okay. So freeze dried it and then applied on the patch, but it would have, okay, so it would need some sort of diluent or gel, right?
Right, yeah. Okay, so the next point is, I discussed that, sorry. So product presentation, what should the product look like physically? A single dose syringe with needle, multiple dose vials with 5 doses, to minimize waste, more waste with 10 doses. to see if you have 10 doses and you can only vaccinate 3 people, you lose 7 doses.
Mhm.
And the dose per container, DPC issues, has received so far little attention, but I find one paper, the effect of DPC on immunization system and program goals, has been reported. And this is here, okay, where you can see 2 situations, a multiple dose, a dose per container, and you can see on safety, positive for this one. It's not very good for this one in terms of safety. I don't know exactly why. The product cost and the wastage is negative for the multiple dose container. It's positive for a single dose, and so on. So this is studies that start to be performed, and which I think are important. Okay.
Are there any, oops, sorry. Oops. Are there any sort of products or packaging that is biodegradable at this point?
I'm not sure that this is a problem, because I mean, you inject the vaccine, so you don't want it to be biodegradable too quickly.
No, I was just not. I'm thinking obviously not like in a like a pill pack or anything, but
okay, now I understand. But the syringes that you have with, they are not biodegradable. At least you have plastics now that are, but I'm not sure that they are.
Yeah.
So you're right. You're right. I mean, if you vaccinate billions of people, this is an issue. You're right. Okay.
I was just curious in terms of if there was anything out there. Maybe I'll develop one.
So then you have the storage, okay, and the storage, it's the ideal is 3 to 8. The storage below 20, I mean, minus 20 and minus 70, which is the case for the messenger RNA, now they are at minus 20, is a major challenge for the developing world. Think about here, you have the long road for vaccination, okay? You can see that you have to send the vaccine from the factory to a national storage facility. This is probably by plane. Then you need to bring it to regional storage facility, and then you have to bring it to the clinic, and then you have to bring it in the remote villages. And if you have a cold chain, this has to be maintained, and that's a challenge. I mean, just to let you know that another student, Bontley, who was in the class 216, did a study on the cold chain in South Africa in 7 centers. And when she interviewed these 7 centers very carefully, she realized that none of these centers had a good cold chain processing, okay? So she made recommendation to the government, and right now this is taken very seriously to try to improve the efficacy. So think about very, very strongly about your thesis project, okay? Because many of the students have thesis projects that are very relevant to their country, and that's what we think is important, that you contribute through this master to solving problems in your country. And start thinking now, because the module 4 exercise will be your study plan for your thesis project. So the sooner you think about it, the better it is. This was just a little parenthesis, okay? This is an option which is called the control temperature chain, the CTC, which allows you to have a certain number of days and a certain temperature. This is a device, for instance. It's a very interesting thing which would solve this kind of problem here, transmission from the clinic to the village, or even from a regional storage facility to the clinic, okay? This would allow you to keep, I mean, your material cold, and that's what is proposed by WHO. I think I'm about to finish. I have, I think, 2 more slides, the packaging and labeling. What do you know about constraints complying with WHO volume requirements? You cannot have, I mean, a vaccine that is in 1 liter. Okay, there is really a limitation. You should think about mock-up labeled with regulatory compliant indications, so that you will have to put that in your TPP, okay, how you want to do that. And what is driving the text that you put on the label? The brand name usually outsourced to a specialized agency to make something a little bit sexy, except I never know why we use these terms of sexy, I mean, for this kind of things, but I mean, that's the way it goes. Acceptable from a regular point of view, should not be misleading, not too close from an existing name or of a different product, easy to remember, and without awkward meaning in a foreign language. Very important.
Does it also need to have like sometimes the insert too in terms of how to deliver the medication? Yes. Is that part of that?
Yeah, yes, this is part of, yes, absolutely.
Okay.
Yeah. So the product registration, I think I'm done with that, okay? I told you a little bit how to do that. And product registration and pre-qualification, this is also an important point. Should know for your first registration in the country of manufacturing, and then in country interested in using the vaccine. The pre-qualification is the goal of WHO vaccine, is to ensure that the vaccine used in immunizing programs are safe and effective. So they pre-qualify the vaccines so that this will simplify their use in developing countries. Very important, through UNICEF. So this is my very last part, okay? Here you have the labeling. You can see this is the Chinese CoronaVac vaccine, okay? Where you have some indications, you have a name. I think this is not necessarily a good name, but Sinovac is maybe a good trade name, okay? And I listed here the vaccines that are currently, I mean, have been gone through the emergency use authorization. As you know, this has been put together because COVID is a pandemic. So we had a very rapid authorization process, which doesn't mean it's not rigorous. And you have Sinovac, Sinopharma, and the CanSino, which are all killed vaccines, okay? This one is an adeno-based vaccine, which are produced in China and are used in the developing world. This one has already been licensed in China because it was used against Ebola. You have the AstraZeneca vaccine with the problems that you know. It's an adeno-5-based vaccine. You have the Johnson & Johnson. It's also an adeno-based vaccine. Pfizer, which is a messenger RNA vaccine. The Moderna, also, and the Novavax, okay? So these are currently the vaccines that had a TPP that have provided the information for product registration and pre-qualification. With that,
do you think that the CoronaVac and its little smiley face symbol is to promote a more positive outlook on the vaccine?
I don't know. I mean, you see, this is business. I mean, it's how you sell your vaccine. As I said, you do that with companies that know exactly how you would
market the.
Yeah, to stop the sharing. Okay. So this was my presentation for today. I hope it's useful. Next week, we will see we will not do the discovery because it's going to be in July. But next week, we have Ivana and myself, we are going to lead the discussion on the preclinical studies, the non-clinical studies. Please, I mean, read them really in advance and ask your questions. I have to say that the two questions from Lyman and Amy are very good, and I think as I did, I mean, I provided you, Amy, with information, okay? So you can read, I mean, this is a very, very nice. I remind also that you can work as teams. You can, I mean, really discuss questions among yourself, either as an entire group or you can split, I mean, and this could be easy. If you're interested in that, I could install the BB Blue, I mean the Blue, what is it? It's a kind of a system that allows you without prerequisite to actually work on documents. So I will install the BB blue button, forgot what the last name is, so that you can actually organize discussions among you. Okay.
So JP, we're supposed to be reading for next time, not the discovery, but the non-clinical testing within the module.
Yes, you have 2 papers, I think, which are associated with it, and you have the content. So
Okay.
I always suggest, I mean, that either you start with the papers if you like to, I mean, see a little bit how things are done, or with the content if you feel more secure because you have already knowledge. Yeah, I know it's a short time, I mean 1 week, but try to do as much as you can. And I will now post the recorded session on the wiki, as well as my presentation. Okay, by the links.
So we're skipping discovery. We're going right to non-clinical testing with the 2 articles that's associated with.
And then we do the discovery. Yeah.
I have one question.
Yes.
I have one question.
Yeah, go ahead.
How about switching vaccine? For example, you receive the first doses for AstraZeneca, and the second doses, for example, Johnson. I don't know.
I think that there have been now some reports where you went with initially an AstraZeneca and then you switched to a messenger RNA vaccine. It is feasible, but I would strongly suggest that you look at it if you are interested to introduce that in your place, okay? First of all, I would contact Ivana. She will provide, because Ivana, she's working, I mean, at WHO, she knows exactly all the specifications, regulation aspects, okay? And use, I mean, the forum to use the forum, because in my opinion, it would be very, very nice that the others know exactly what you're doing, okay?
Okay, thank you.
Okay, was very nice. I mean, I appreciated your questions. I mean, it's a lively, it's more lively than it used to be in module 1. So I think you learn how to take much profit of this bi-weekly session, which will be weekly for next week. Okay.
Thank you. Enjoy your cello this weekend.
Bye-bye.
Thanks. Bye, everyone.
Bye.
Bye-bye.